it the stages like 1, 2, 3, 4. So when the macroadenoma more than 3 centimeter and it is remaining within the cellar below the diaphragm. So it may be elevating the diaphragm, but within the cellar area, then it is 1. When it extends into the cavernous sinus and it engulfs the carotid artery, then it goes stage 2. And when it lifts the roof of the cavernous sinus, and the roof of the cavernous sinus it's lift and it grow into temporal or frontal lobe, then they said such tumors are usually they found very aggressive and they do prefer a transcranial route. And the last stage was when they engulf they breach the arachnoid layer and going intracranially subarachnoid area and extending around the anterior cerebral artery of circle wheels. So that tumor they better do deal with from the transcranial route. So that was his idea.
So,
Yeah.
considering that the patient has a CSF leak, a pituitary tumor, we know that there is an extension into the third ventricle.
Yeah.
Would you want to relatively do a preoperative
Lumbar drain, we are planning it after the surgery, and we have neurosurgeon with us, Dr. Karthik Moda sir. So the lumbar drain and all that question, I think he will be the good person to answer you.
Good morning all. We are warm welcoming Dr. Karthik Moda sir in our OT. So thank you sir for giving us opportunity and learn from you. Thank you so much. We are warm welcoming you sir. Thank you sir.
Yeah, just a minute.
Keep it closer.
Hello? Yes?
Good morning, Karthik bhai.
Good morning, yes. Are you able to hear me?
Yes, very clearly.
Yeah. Regarding lumbar puncture, I think it will be a post-op procedure. Preoperatively expecting the CSF leak, lumbar drain can be put, but if we remove the CSF, then sometimes the bulging will go away and excision will be slightly less radical. Hello?
Yes, sir, we are able to hear you.
So when we feel that there are chances of CSF leak, we can put lumbar drain preoperatively, but we are reluctant in draining the CSF.
Right.
After the surgery and closure and packing and everything, we can start on draining the CSF, and that we can continue for about 3 days, and gradually we can stop draining CSF, and if it is there is no rhinorrhea or anything, then we can remove the drain.
Okay, sir.
So,
Sir,
yes, anything else you would like to comment regarding the pathology? What do you suspect?
sir, a locally aggressive tumor would essentially want to count this as a malignant tumor. Definitely, as there are two doubtful signs that probably what could be leaking. One was a direct extension into the third ventricle, and on the ventricle cut, I could see a CSF form.
Yeah.
All the way down into the nasal cavity. If you can towards the CT scan surgery cut.
You think it is pituitary or anything else?
Definitely pituitary tumor. Looks like a pituitary tumor because they're able to visualize the stalk of the pituitary tumor.
Yeah.
We're not able to discretely differentiate between pituitary tumor and the tumor. And the normal gland.
Yeah.
I believe the gland is laid posteriorly and superiorly right above the tumor.
Less possibility.
Parameters would definitely put as the first differential being the pituitary tumor.
Okay. Less possibility, but can it be a chordoma?
Less likely, sir. Very less likely looking at the CT cuts.
Okay.
Because what we see on the CT is not very characteristic. There is no bone.
Yeah, there is no bony erosion. Yes.
The lateral bone looks quite solid.
Yes,
but
clivus is intact.
The window CT scan, probably we may be able to.
Yeah.
Sir, we have the DICOM pictures.
આમાં જ રાખો.
Sir, we have the
And one more thing, usually we find a means a single cyst whenever there is a cystic tumor.
Sir, Rakesh sir, not able to hear you.
Yeah. Now is it okay?
Yeah, better.
Yeah. Usually we find a single cyst in the tumor whenever there is a cystic pituitary.
Right.
Here it is a multiseptate, so that is also an unusual thing.
Right.
And I think frozen can also be more helpful if possible.
Definitely.
Regarding the radical nature of the surgery, whether we have to go radically or we can conserve some more. Anything else regarding the carotid?
Regarding what, sir?
Internal carotid involvement?
External carotids, sir, relatively looks free of the tumor.
Yes.
So this.
There is somewhat surrounding involvement. I think it is there.
So here.
Here in the basal cut, I think both carotid are involved inside.
You have to move.
Okay. If you can see here. Hello.
Yes, sir.
And then થોડુંક નજીક લઈ જાઓ. So here I think both the carotids are there inside the tumor, and one unusual thing is that right side we have a lateral cyst is also there in the cavernous sinus, and that is also unusual.
Sir, could this be a CSF pouch?
CSF pouch is there, but it is in the superior cut, which where it is coming from the third ventricle.
Right.
If you can, here it is coming.
Yes, exactly.
Here, so this is a CSF pouch, but I think another cystic areas which we are seeing here, especially in the right side cavernous region, paracavernous region. This is, I think it is not CSF, it is the tumor cystic region. CSF pouch is here only, I think, and there are chances that if arachnoid is breached here, we may have profuse leak.
Regarding excision of the tumor,
Yeah.
what is your, would you want to like go ahead and do something like a complete excision with drop total removal of the tumor? What would be your thoughts?
See, if you are suspecting that it is a pituitary, there is no need for going gross total resection when there is an unusual radiological picture, because there are chances that vessel involvement and attachment will be there. If you are suspecting any other pathology than the pituitary, then I think radical resection or radical dissection is more to be thought of, advisable, because pituitary we always have a backup of radiation and we can manage it.
And the complication of hypopituitary.
Yeah. So that is my opinion. So that's for regarding that only I was asking you about the possibility of chordoma.
Sir, the only reason is I don't see any bone erosion, don't see any.
Yeah, you are right that there is no bony erosion. So chances of chordoma are that, but regarding the preoperative decision whether the radical resection is required or not, see, if it is chordoma, then there are chances that radio-resistant tumor it is more likely. So in that case, you try to be as more radical and as more aggressive as possible, because it is bound to regrow and recurrence rate are high. But in pituitary, there is always that if you feel that it is there are chances of complication, you always have a backup of radiation. So whenever there is pituitary and there is a compression element is less, especially on the optic chiasm and optic nerves, then we can always remain conservative in our resection.
Sir, can somebody show us the cuts on the laptop?
આ બાજુ જો.
ચાલો.
These are DICOM images.
Yes, sir.
Are you able to see?
Yes, sir. Very well.
We are going from base to up.
Spinal cord looks quite
બંધ કરો તો nice and
Yeah. Yes. So So here the tumor involvement is there. Yes, go down. Again, little bit. Still. Here. Okay. Now go back again. More down. Next. Yes. Towards the base. And you are coming up. You want to go down. Just a minute. Yes. Hello. Yes. Huh?
Neurosurgical point of view,
Yes.
if you come across a patient or if you treat tumors, what
Yeah.
is the algorithm management or how do you go about investigating these patients and what are your
Yeah, just a minute. Yes, see, here it is the clivus part, and bone towards the sella as well as towards the brainstem. It is the bony margin is intact, if you can appreciate. So, chordoma chances are less. Now regarding the workup for pituitary tumors, whenever we are suspecting a cellular lesion, and mostly they are the pituitary. Occasionally rat case cleft and other rare pathologies are there. But general workup we start from now you are able to hear? Yes. From radiology point of view we will require both MRI, and that also particularly now they are doing pituitary protocol. So they will give thin sections regarding at the place of sella and paracellular region along with contrast study. And along with that, CT-PNS with bony window R is the must. And blood investigations, routine pre-op blood investigations, and complete hormone profile is the must for that.
hormone profile is concerned, I mean, is there a specific timing where the blood needs to be withdrawn that the patient has to
Yes. Can you repeat and can you be little bit louder?
Is there a specific time during which the patient has to give blood for a hormone?
Yeah. Hormonal regarding the cortisol, we require both. Means in NBM state as well as in the random state. In another growth hormone TFT, also NBM is the must. So we take two samples. One is NBM for the general hormone profile, and for cortisol we also require a random. Okay.
Sir, what is the reason behind the new time?
There is diurnal variation in the cortisol level especially, and in thyroid function test they say that there are some variation. When you take a random blood sample, free T3 and free T4, there is some variation. TSH we can have it in random. So for that reason only we require NBM sample as well as the random sample. And yes, another will be regarding the workup. Another workup will be from the ophthalmo point of view. Visual acuity, fundus, and perimetry is also a compulsory thing. Even though patient is not having any complaints regarding the vision, whenever we are going for surgery, pre-operative, this documentation is must, I think.
Sir, when it comes to planning surgical approach, is the planning different when it comes to secreting tumor versus non-secreting tumors?
Secreting tumors, yes, there is not much difference, but in secreting tumor, we try to remove that portion. While in non-secreting tumor, it is a general resection. So debulking is the main aim in non-secreting tumor. But in secreting tumor, we have to find out that particular region. And in MRI, many of the times they are suggesting that it is anterior or it is laterally lying or posteriorly. But per-operatively, in my experience, it is difficult to differentiate from the normal pituitary tissue and the adenoma tissue in endoscopy as well as the microscopic excision. What is your experience? Are you able to identify microadenoma?
Sir, we're not able to hear you well, sir.
Yes, so it is theoretically it is said that you have to only remove the microadenoma and you have to preserve the normal tissue, but it becomes slightly difficult.
Right, sir.
So regarding the approach and planning, non-secreting tumor, anyway, see when there is a secreting tumor and tumor is small, the cellular portion of the cellular defect we are creating, that can be a small and we can go in that. But when there is a non-secreting and when you are having a macroadenoma, try to make cellular defect as bigger or as wider as possible, so that the maximum amount of resection is possible.
Sir, when it comes to decision making between endonasal surgery versus transcranial surgery,
Yeah.
what are the factors that determine the approach?
See, when there is a paracellular extension and operating surgeon is well acquainted with all these wide endonasal approaches, then endonasal is the best. But in transcranial, usually when it is extending in the frontal lobe or in the third ventricle, and in that portion, transcranial excision I think will be more helpful. So when you require when you have to go around away from the midline, and it is in the transcranial portion, not in paracellular region. Paracellular extension, it is slightly more easy from the endoscopic point of view or endoscopic approach rather than transcranial. Would you like to comment anything when whether it is a tumor is non-pituitary and meningioma sort of?
We didn't get your question, sir.
See, suppose it is a plenum spinoidally meningioma.
Yes, sir.
Then what do you think? What will be your approach? Endonasal or transcranial?
Spinoidal meningioma, definitely endonasal approach has an edge as far as we as cranial-based surgeons are concerned, because it devascularizes the tumor the moment you guide away the bone.
Okay.
So
Okay.
that for us
Yeah.
gives us a better distinction.
Okay. Yes. Yes.
Sir.
We have sir with us, Dr. Tulsidas sir, and I will hand over mic to him.
Yes, sir.
So please wait for a while.
Yes, sir.
Excellent. That excellent. Please, go ahead. Okay, yes, sir. This one. Hello. Are you working on it? Yesterday you start working. In the back. Good morning, sir. Hello.
Yes, sir.
Can you hear me? Auditorium? Can you hear me?
Yes, very well, sir.
Oh, good. So, good morning to you all. Very good morning to you. 6 right? I'll just see the CT scan one more time. I can't hear exactly what you're saying. Can you repeat that, please?
Sir, can you read out the CT and MRI as if you are planning the scan or reading the scan for yourself?
I think it's already been discussed. So I think only I'll be repeating what has been done.
What are your points in planning the management of the patient?
Oh, I'm only a technician here, planning the management of pituitary tumor. As you know, pituitary tumor is basically an endocrine problem. So in our center, we closely collaborate with the endocrinologist, and as per their suggestions, we take up cases for surgery. So we have endoscopes, and we are able to get into the sphenoid without any difficulty. So we happen to do the surgery for the endocrinologist, right? And also the neurosurgeons also, because they've been doing for a long time, more than 100 years. So I think they also do the surgery because this happens to be very close to the brain.
Right.
So that is where we stand. So I am just a technician doing the surgery. But then the perioperative management of these cases are very important, because there are some problems the patients can get into. So we try to avoid those complications, and then hand over the patient after a week or so to the endocrinologist. Okay. Yeah. So I think I am more than the MRI. I would like to see the the pneumatization of the sphenoid sinus. In a CT we see that better. So here is well pneumatized. I think this is post-cellular kind of pneumatization, probably complete post-cellular. I'm not too sure because the pituitary shadow comes in the way. And fairly big tumor here. I think this is confined to the cella itself. I don't think there is any supracellular extension. I think probably in the MRI you see a little bit. I'm not too sure unless we go in there. It's not a big, even if there is an extension beyond the diaphragm cella, it is not too much. So I think we'll be able to handle this. But the CSF leak, I'm not really worried, because many times when you do surgery, you do get some amount of CSF leak. So that's not a problem. You can always plug it. And Dr. Umang was suggesting we should harvest a Haddard flap. So are you planning a Haddard flap or?
No, I leave it to
Okay. Because I'm not a fan of Haddard's flap, nasoseptal flap. I'm not really a fan. So that's not bad. So because this is one area where we harvest the flap first and then do the surgery later.
Right.
So I'm not really fond of it, no. So, but unless you harvest the flap first, you're not going to get a good vascularized flap if you are looking for one later on. So that is the reason they harvest the flap the first incident itself. Before tackling the tumor, they harvest the flap and keep it in the nasopharynx usually.
What is the best alternative for Haddard flap, sir?
Best alternative for Haddard's flap? I can't think of anything for the nasal cavity and yeah, I can't think of any alternate. But that's the reason I think Haddard flap is very popular with many people. I once heard one ENT surgeon saying, I have harvested more than 200 Haddard's flaps. So I have tried in a few cases, but I am not really happy with the thing, because we can't really know what is happening under the flap. And to make the flap sit in place, you need to completely remove the mucosa of the nasal cavity so that the flap will go and sit comfortably on the bone. Otherwise, you will get a mucosa later on.
So you are planning to close the CSF with fascia?
Yes. Because it is harvested from the side. So see, the thing is, once we go in, we deal with the tumor and we know where exactly the CSF leak is. Then we decide what kind of material to put in there, and we'll harvest. So in situations like this, we harvest the fat from the thigh and also facial hair.
Alright, can we predict the tumor will be liquefied or solid?
I can't say, I don't know, for all you know there may not be any tumor now because CSF has come into the cellar. CSF has come into, so that means probably the tumor itself is maybe very small by now. This happened, this enlargement of the pituitary probably happened long back, the tumor was big. But right now if there is a CSF leak, probably most likely, the CSF has come down into the cellar.
What's your plan? You are going to remove turbinate both sides?
Terminate both sides? No.
Hello, auditor, Hitesh bhai.
I am on.
Sir, Hitesh bhai, we have plant navigation system in this case.
Very nice.
Yesterday also we set up this case, but during that innovation and everything was going on, so we couldn't But today we see actually you can ask the sir all the question around navigation.